Hi everyone, this is Tiffany Williams. I am the FNP Program Coordinator. I'm going to provide a brief overview of neurosurgery and orthopedic imaging and common terms that you will hear throughout the program and once you graduate and start working. There are a multitude of different types of imaging that you can obtain. The biggest ones used in neurosurgery and orthopedic surgery are X-rays, MRI, CT myelograms, where they inject dye into the actual spinal column, discograms, and arthrograms. If you don't work for an orthopedic surgeon or a neurosurgeon, likely you're not going to be interpreting MRI, CTs, myelograms, discograms, or arthrograms, and you're definitely not going to be the one ordering the myelograms, discograms, or arthrograms. X-rays will be the one that you may be in charge of interpreting the most, so we will spend the majority of our time discussing that today. To the left of the slide, you will see a normal x-ray of a lumbar spine. I chose this to start with because this is the easiest to look at because there's so much space in the lumbar spine. I have labeled all the different parts. We'll start with the bones. The vertebra is what you should look at first. Okay, do you see any abnormalities? They should look like rectangles. As you see in this image, all of them look the same, and that's good. That means there's no fractures, there's no abnormalities in any of the bones. It actually looks like this person has pretty good bone density. We don't see any evidence of osteopenia or osteoporosis, and you'll see that where the bones kind of start fading into the background as it gets worse. At the back of the spine, there's several different parts that you'll look at. The foramen, the little hole, the black area right behind the vertebral body, that's where the nerves actually come out and go down into the legs, into the lower extremities. The spinous process, if a person has a fall or a motor vehicle accident, we see spinous process fractures a good bit. The pedicle is what attaches the vertebral body to the back of the spine, along with the transverse process, and you'll see fractures there in traumatic accidents, falls, motor vehicle accidents, etc. In between each vertebral body, there is what's called a disc. That is the shock absorber of the spine. If you notice on this, all of them are pretty evenly spaced. That means we have normal disc height. Okay. If you see that there's one where there's only a very small distance between the vertebral bodies, that means that they have lost that disc height or they have disc degeneration. If you see outgrowths of bone on the front of the spine, which at L3 and L4 you start seeing that a little bit, those are osteophytes or bone spurs. Those can form at the front or the back of the vertebral body. If they're on the back, they can pinch the nerves that are coming out of those foramen and cause radicular pain. So when you're looking at this x-ray, first you're going to look at the alignment. Are all the bones sitting on top of each other? Yes, they are. So normal alignment. You're going to look at the disc height. This looks like normal disc height, so you don't see any disc degeneration. There's no fractures, and there's very minimal osteophytes on this x-ray. On this slide, we have a normal cervical spine x-ray. The cervical spine is much smaller than the lumbar, so it's harder to see, but everything is labeled. Again, it has everything that the lumbar spine has. It's just a much smaller space. So you can see bone spurs, you can see disc space narrowing, etc. In the cervical spine, there's much less disc space in between each vertebral body, but it should all look symmetrical. If you have one that has a much smaller disc space than the rest, then they have disc degeneration at that level. In the cervical spine, you see a lot more osteophytes or bone spurs usually. And most of the time they're on the front of the spine. If they're on the back, again, it can impinge the nerve coming out of the foramen. In the cervical spine, in traumatic accidents, you can have fractures to the vertebral bodies, the spinous processes, the pedicles. The problem with this is, and in the thoracic spine, this is where the spinal cord is. So they're much more likely to have some type of neurological deficit if there is a bad fracture in this level. On this slide, I've included some of the abnormal things you may see. So if you have someone that comes in and they're having severe acute back pain and they fell recently, and you get an x-ray and you see what is shown in image A, that's a wedge-shaped compression fracture, okay, meaning that vertebral body has been compressed down and it now has a wedge in the anterior superior end plate of the vertebral body. That can cause a lot of pain because there's bone missing. One thing that you should know about a fracture is that in the spine, if you fracture a vertebral body, it's never going to look like a normal vertebral body. It will always have that wedge shape to it, even after the bone remodels, because it will never fill in and become a rectangle again. Okay, so in 30 years, if you see the same patient with this compression fracture, it's going to look the exact same. In B, this person has some osteoporosis. The bones are starting to look more demineralized and the bone has fractured because the bone is weak. Okay, people with osteoporosis don't have to have a traumatic injury. They don't have to fall. They can turn over in bed, cough hard, sneeze, and fracture a bone in their spine, unfortunately, especially when they get into severe osteoporosis. In image C, we see disc degeneration. Okay, so if you look at on the lumbar spine side, the last two levels, those disc spaces are much more narrow than the rest. That's disc degeneration. Okay, that causes pain because there's not as much shock absorbent left in between those two bones. So when they walk, when they stand, it causes pressure, which in turn causes pain. If you look on the cervical spine side, the top three levels look normal. And you get to those lower levels, there's not much space in between those vertebral bodies. Okay, so that's disc degeneration. In image B, you'll see bone spurs on the front of the spine where those arrows are. Those bones have actually bridged the vertebral bodies and connected them together. In E, this is called spondylolisthesis. This is where one bone anteriorly subluxes on top of the bone below it. You can also have posterior subluxation where it shifts backward. It can actually shift laterally also, which you're only going to see on an MRI, not on an X-ray. But they have spondylolisthesis. They also have severe disc degeneration. If you look at that level with the spondylolisthesis, there's no disc space left. So this person probably has back pain associated with that deformity. This can be a congenital deformity. They can be born with a spondylolisthesis. It could be a traumatic incident where they now have fractures called pars fractures, which you don't need to know the specifics of that, but the fractures in those areas can cause that bone to shift out of place. So if you see that and the person is complaining of a lot of back pain, it could be from there. Another very common issue is scoliosis. You'll see this a lot in pediatric patients and in much older patients. The more severe the curvature is, the worse the pain is going to be. The image at the bottom is someone who had scoliosis and actually went through a spinal fusion to correct it. And they look much better after the surgery than before. This can cause significant back pain. And when the curve starts progressing, they can actually develop heart and lung disease because of the increased intrathoracic pressure. It can also cause nerves to be pinched, so they can have radicular symptoms. This can be a congenital deformity where they're born with scoliosis, their spine just doesn't form straight, or a degenerative process where their discs have started degenerating and it just slowly causes a curve in their spine. It can also be traumatic if they have some kind of traumatic fracture that causes the spine to curve. Next, we're going to move into some ortho imaging. I am not an expert in orthopedics. I do neurosurgery. I do look at a fair number of orthopedic x-rays. The top left, you'll see a normal joint. You see that there's good joint space between the ball of the shoulder and the socket of the shoulder where that humerus is fitting into the shoulder. You don't see any fractures, no outgrowths of bone anywhere. That's a normal shoulder. That's what you're supposed to see. In the second image to the right, this is advanced arthritis. You see some bone growth at the top of the humerus. You don't see hardly any joint space left. That person probably has some significant pain in that joint. You'll probably feel some crepitus when you rotate that joint around. You may feel some rubbing sensation where the bone is actually rubbing in the socket. In the bottom left, that humerus is displaced. Okay, it'll come in and you'll usually see it where the shoulder doesn't come out where it's supposed to. Usually you'll see that in urgent care or ER. To the bottom right, those are fractures. So the first picture, the humerus is fractured at the head of the humerus. The second, you see a bone kind of broken off in the middle of the head of the humerus. Those cause significant pain, and they're going to be in the emergency room usually. Hip imaging. So the middle picture is a normal hip. You have a good joint space left in that hip. It doesn't look like it's rubbing. You don't see any bone spurs. There's no fractures in the hip. The bottom left, that's someone who's had a total hip replacement. Okay, so you see all metal in there, and then the rod actually goes into the middle of the femur. The biggest picture I put up to the top right, that's hip joint degeneration. So you see where the bone of the top of the humerus is actually rubbing in the socket of the pelvis. You can see some outgrowths of bone. It looks sclerotic is what we call it. Bone sclerosis in there. And then the bottom picture is a fracture. Pretty evident where the head is left in the socket, but the femur is kind of protruding out right there. So that person's going to end up with a hip replacement that you see to the left. People have a lot of pain when they develop joint degeneration because every time they take a step, that ball is rubbing in the socket and it's bone against bone rubbing. So you'll hear crepitus. They may hear clicking and popping when they walk. It's usually a progressive issue, so they'll notice it and it just gradually gets worse and worse. Here's a few pictures of the knee. The first one up at the top left is a normal knee. Everything is evenly spaced out. There's no bone spurs. That's an amazing knee. I don't think I've ever seen a knee look that good in practice. The top right is a knee replacement. Very interesting surgery if you want to look that up on YouTube. Not a pleasant surgery to watch. Down in the left is the AP view of joint degeneration. So you see on the left side of the picture, there's pretty good space between the two bones. On the right side, there's no space. Okay, so that joint has degenerated. And then to the right, you see the lateral view. You see where the two bones are pretty much sitting on each other. So again, just like with the shoulder and the hip, you're going to have a lot of pain. You're going to have clicking, popping, rubbing, grinding. Every time they take a step, they're going to have pain, and it's a progressive process usually. And they're going to notice that just over time, it gets worse and worse with the pain. Next, we're going to just go over some common terms that we see in neurosurgery and that you're going to see on x-ray or MRI, CT, radiology reports. So if you order an x-ray or some other imaging on a patient because they come in complaining of back pain or radicular pain and you get imaging, and you read what the radiologist has said, this is what they're talking about. So the disc, we talked about that. It's just cartilaginous material between the vertebrae. This is the shock absorber of the spine. This is going to degenerate over time. Okay, the older you get, the more disc degeneration you're going to have. And you may see people that come in to see you and you get an x-ray of their spine and they have no disc left anywhere. Okay, they've usually worked some kind of hard job where they've been standing on their feet for long periods of time, for years and years and years, and it just degenerates that shock absorbent. Okay, so next, disc degeneration. It's just where you lose the hydration and height of that disc. Okay, so it becomes hardened, and there's just no cushion left in between the bones. Okay, disease, it's not the same as just having disc degeneration, because you can have just one disc degenerate in the spine. When you give someone the title or the diagnosis of degenerative disc disease, that means they have multiple discs that have degenerated, and it looks like a progressive degenerative process that's happening in the spine. It's very common. I usually tell patients in neurosurgery, if you live long enough, you're going to have disc degeneration and arthritis somewhere in your body. You're going to have joint degeneration. It's going to happen. Most commonly in the lumbar spine, because that's what takes the majority of the axial loading in the spine. Common in the cervical spine also, because the discs are so small there. Okay. Facet arthritis, you'll see that on x-rays. Facet arthropathy, radiologists call it that. Facet joint disease, they may say that on there. So the facet joints are located at the back of the spine, and it gives the spine stability, and it allows the flexion extension of the spine. So over time, these joints start degenerating just like every other joint in your body. It's more common in obese people, people with poor body mechanics, advanced age, and repetitive overuse. So if you have a job that requires frequent bending, you're going to put more pressure on certain facet joints in your spine. Usually associated with disc degeneration. Once those discs start degenerating, it puts more pressure on the facets, causing degeneration of the facets. You can have patients that have some mild disc degeneration, no other findings in the spine except facet arthropathy, and have severe back pain. And it's because every time they move, those joints are rubbing on each other. Degenerative spine disease is a little different than degenerative disc disease. That's a combination of a multitude of issues involving progressive deterioration of the spinal structure. So they'll have disc degeneration, facet arthropathy, or facet joint cysts, things like that. They have bone spurs that have formed. And all of that combined is when we give someone a degenerative spine disease diagnosis. Spondylosis, you may see that on a radiology report, and it's just degenerative arthritis of the spine. So if you have somebody that has spondylosis on their x-ray report or MRI report, you can tell them they some type of arthritis in their spine. You don't need to be specific with what it is. Spondylolisthesis, we talked about that. It's more common at L5S1, and second is L4-5, because those two levels take the most axial loading to cause that, or it could be a congenital deformity like we talked about. There's multiple grades. Likely, unless you work for a neurosurgeon, you're not going to be grading the spondylolisthesis, but it's grades 1 to 4, and then grade 5 is technically spondylosis. I can't talk, I'm sorry. And that's where there's no, it's completely sublux. It's extremely rare, except with severe trauma. The higher grades are usually associated with nerve impingement, and that's when you'll see people with pain radiating down the legs. Failed back syndrome, you may see these people in family practice, urgent cares, because they come in with back pain that just never improves. Those people they fail to improve when they have back surgery, okay? And it's usually caused by a multitude of things. Number one, the pain that was supposedly being treated with neurosurgery was actually caused by something other than spine pathology. Okay, it's psychosomatic pain, or the back pain and the pain down the leg was actually caused by hip pathology, not the spine. Or it could be that they have so many different issues in their spine that one surgery is not going to fix it, and they're just going to live with back pain for the rest of their lives. They can have permanent nerve damage that causes failed back syndrome. They typically don't return to work, and they require pain management. This isn't a common occurrence. Usually, you can figure out where the pain is coming from and help them. Scoliosis, we talked about that. That's just an abnormal curvature of the spine. You can have levoscoliosis, where the convex is to the left, or dextro, where it's to the right. They can require surgery. If it's too advanced, a lot of times surgery is not an option because it's not going to help them. It does cause a lot of pain. It can cause spinal stenosis, which causes more pain. Kyphosis, we see this a lot in older people, especially little old ladies. You see they look hunchbacked, and that's because there's outward curvature of the spine, usually in the cervicothoracic region. And it does cause pain because it's putting a lot of pressure in that area. Some more common neurosurgery terms, and I include a lot of this because I see people refer to us from family practice clinics, urgent cares, ERs, and the provider there didn't give patients enough education on what they saw on imaging. So spinal stenosis, that's narrowing of the spinal canal. This can be congenital, degenerative, or traumatic. They can be born with small spinal canals. A lot of times the radiologist will say this, that it looks like a congenital small canal. And they know that because the entire canal is smaller than it should be. Usually canals are somewhere around 10 millimeters. Some people have much larger canals, but if the entire canal is smaller than normal, then it's usually a congenital deformity. It can be degenerative, where things just start pushing on the canal. And if the canal narrows enough, it puts pressure on the spinal cord or the thecal sac. So the spinal cord ends at T12. Below that is a thecal sac that contains the nerves. Okay, so when you put pressure on either the spinal canal or the thecal sac, it causes pain and radiculopathy. Okay, nerve impingement. This is when something puts pressure on one of the nerves that's coming out of the spine. And this causes pain, numbness, tingling, weakness along that dermatome. We've all heard of, the dermatomes where the nerves innervate the body. And each level of the spine has a nerve that comes out of it that innervates a particular part of the body. Okay. You develop weakness when that nerve is severely compressed. Usually it starts with pain, progresses to numbness, tingling, and then weakness occurs. Disc herniations or protrusions, those terms are used interchangeably. And it's just when the annulus, which is the wrapping, the outer surrounding of the disc, is torn or weakens, and disc material protrudes out or herniates out of the disc space. And it pushes on the thecal sac or the nerves exiting. And that causes pain, numbness, weakness, because again, you're causing nerve impingement. You can have people that have a disc protrusion or herniation that it's not causing any pressure on any nerves, and they're not going to have pain associated with that nerve. They can still have back pain associated with, now the disc is smaller than it was before, so they have less cushion in there. Sciatica. A lot of people use this term interchangeably with radiculopathy. They're not the same. Sciatica, there's a specific sciatic nerve that originates in the buttock and extends down the back of your leg. So patients attribute any pain that radiates down their leg to sciatica. Okay, true sciatica is only when there's injury to the actual sciatic nerve, which is rare. If a patient has irritation around a spinal nerve and the pain shoots down the leg, it can be called sciatica. We call it radiculopathy in neurosurgery because it's a group of symptoms that's caused by irritation or injury to a nerve root that is exiting the canal and going into the extremities. So if it's a nerve in the cervical spine, usually you're going to have pain, numbness, weakness, tingling in the upper extremities. Thoracic spine causes the radiculopathy or radicular symptoms around to the chest and into the upper abdomen. Lumbar is going to be the lower abdomen, groin, and lower extremities. Myelopathy is when you're compressing the spinal cord itself in either the thoracic or cervical region. Because remember, the spinal cord ends at T12. The only way you'll have myelopathy caused from the lumbar is if the spinal cord is low-lying, where where it extends down into the lumbar spine, or it's tethered, which is a whole other thing that we're not going to get into today. But myelopathy causes pain, tingling, numbness, weakness, decreased fine motor skills. It can cause increased reflexes below the level of the spinal cord injury and decreased coordination or balance. Okay, so you're going to have myelopathy at and below the level of injury to the spinal cord. So if you have a complete spinal cord injury or complete impingement of the spinal cord, you're going to have para or quadriplegia. Okay, if it's depending on what level it is. And you can also have incomplete, which causes para or quadriparesis, which this can improve to an extent with treatment and therapy. Once you develop para or quadriplegia, it's not likely to improve. Okay, and I've also included on the next slide the nerve distribution. Foot drop. I'm sure we've all seen someone with foot drop. It's just where they are not able to dorsiflex the foot, usually caused by L4, nerve root irritation or injury, or L5. They'll drag their foot. They'll complain about having to, physically pick up their foot every time they walk. They'll trip, things like that. Cauda-equina syndrome. Usually you're going to see that in the ER because patients acutely develop weakness involving their lower extremities. They'll complain of numbness in their saddle, which is the buttock, groin, genital region. They'll have bowel and or bladder dysfunction. They'll either have retention or incontinence. They will not have an Achilles reflex. They usually have low back pain and sciatica. And they'll either have very weak or no anal sphincter tone. So if you work in a hospital and you've seen someone come in and seen a neurosurgeon or ER hospitalist doctor check anal sphincter tone, it's usually because they suspect Cauda-equina syndrome. This image just shows you the nerve distribution. Also included another image to the right that shows you where the trigeminal nerve innervate, because you may have somebody with trigeminal neuralgia, and that kind of shows you that. But to the left, this shows you where every nerve from the spine innervates. So the cervical spine innervates the head down to the arms. Thoracic innervates part of the arm and then down to the upper abdomen, and then the lumbar goes down into the leg. And then you have the sacral nerves that innervate the back of the leg. So it's good to know. You don't need to memorize this because you're likely not, unless you work for a neurosurgeon, which you'll get most of that on the job training. But it's helpful to know which nerves innervate which part of the body. As a nurse, it's good to know this, so you know what you're checking for, especially if you work in an ICU and you're checking to see where someone can feel, when you're looking for level of sensation. And the person has a T6 spinal cord injury. You'll know that they're likely not going to have any feeling at or below, around just below the nipple down. Okay, T5 will be about the nipple down. It's important to note that C3, 4, and 5 are what control the diaphragm. Okay. So now we'll move into some ortho terms. Again, I'm not an orthopedic expert, but these are some terms that you probably need to be familiar with, especially if you're family, adult gero primary care, or adult gero acute care, because you'll likely see these. So the bursa is just the small fluid-filled sac in the joints, reduces friction. Okay. Meniscus is the cartilaginous shock absorber between the femur and the tibia and the knee. Commonly injured ligaments, I wanted to throw this in there because you will likely see this at some point, or you already have. So you have the cruciate ligaments, so people that have ACL or PCL tears, it's the anterior cruciate ligament or the posterior cruciate ligament in the knees, or the collateral ligaments in the knee, which is lateral or medial. So if they have an MCL tear or an LCL tear or injury. Labrum, you'll see a lot of people, especially very active people that play sports or things like that, with labrum tears. We also see this in older people that have labrum tears in their hips. It's just a cup-shaped cartilage that reinforces the ball and socket of the hip. Okay. Rotator cuffs. You'll see a lot of people with rotator cuff injuries and tears, especially in older people or people who have played sports their whole lives or been very active or do things that involve repetitive movements of the shoulders. And the rotator cuff is just made up of a bunch of muscles: the supraspinatus, the infraspinatus, the teres minor, and the subscapular muscles. And it just keeps the ball of the humerus in the shoulder socket. So if they tear this, causes a lot of pain, impingement. A lot of times they're not able to reach to put their arm behind them. If you're a female, you go to fasten your bra, they have very hard time doing that, or lifting their hand behind their head to brush their hair hurts, things like that. And they usually do complain about it. Even if it's a small tear, it can cause a lot of inflammation in their shoulder, and they will have a lot of pain. Bunions. Hopefully you will all see a bunion in your life. They can be pretty nasty. They can be really small and not cause any pain. But once they start outgrowing enough to cause pressure in their shoe, they're going to complain of pain. Okay. And it's just an overgrowth of bone on the joint at the base of the great toe. It can be red, inflamed. They can develop sores at this level, at this area, because it's rubbing on their shoes. So very important, especially with diabetics. You need to be checking to make sure they don't have any sores at this level. Carpal tunnel syndrome. This can be either neurosurgery or ortho, and so is cubital tunnel. A lot of ortho guys treat this. Neurosurgeons also treat it. So it's just compression of the median nerve at the wrist. So you're going to have a patient that comes in complaining of numbness involving the first 3 digits of the hand. It's going to be worse at night, worse with driving. They're going to complain of dropping things. They're just going to be holding a mug, and all of a sudden their hand releases it. Okay, but the hallmark sign is it wakes them up at night. They have to shake their hand. It goes away, then go back to sleep. Okay, it's the first 3 digits is what the median nerve innervates. Okay, cubital tunnel is where you have entrapment of the ulnar nerve at the elbow, and that innervates the last 2 digits of that hand. Okay. A lot of times they have carpal and cubital tunnel together, especially if they perform some kind of task that involves repetitive use of those areas. Carpal tunnel is most commonly seen in people who type a lot, people who sew a lot, things like that. Okay. Ganglion cyst, you're going to see that. When I was in clinicals, my preceptor called this a Bible cyst, because people get these little cysts that are on the tendons and joints of the hands and wrists, and they would put their hand on a table, and somebody would take a heavy Bible and slam it on their wrist to pop the cyst. Okay. It can also occur on the ankles or feet, but this is much less common. And it can compress the nerves if it grows big enough, so it can cause a lot of pain, or pain radiating into the hand. And usually they resolve spontaneously. If they get big enough or they cause enough pain, they can be removed. A few more ortho terms, something you're going to see a lot, no matter where you practice. You've probably already seen this. Bursitis, and it's just inflammation of the bursa. Most commonly occurs in the shoulder, hip, and elbow. They're going to have a lot of pain. It usually comes on acutely in that area. Pain with motion. Get an x-ray and they won't see any fractures or anything. And it's just inflammation in that area, usually because they have some kind of degeneration or they've had some kind of injury to the area. Another common complaint is plantar fasciitis. Very painful, very painful. Every time they take a step, it's going to cause shooting pain, and it's just because there's inflammation to what's called the plantar fascia. And this is a piece of very thick material that connects your heel to your toes in the bottom of the foot. So every time they walk, they're getting severe pain. There are a lot of exercises you can do. You can have injections. I've heard from multiple patients the injections are very painful, but they do help. Some people end up having to have surgery, especially if they have bone spurs in the bottom of their foot or in their heel that's causing the plantar fasciitis. They can have surgery to treat that. Something that happens with runners is shin splints, and otherwise known as medial tibial stress syndrome. And it's just inflammation of the muscles along the tibia. Common in runners, like I said, because they put a lot of stress on those muscles. It's painful every time they take a step. It feels like their tibia is being stretched, and they're going to complain of pain along their tibia. Okay. Tendonitis, very, very common. It's an overuse injury or repetitive use injury, and it's just inflammation of any tendon. Okay. And it can be in any possible tendon. Trigger finger, you're going to see that is where one of their fingers gets stuck in the bent position. And it's because this is a type of tendonitis or tenosynovitis where there's inflammation in the tendon attaching that finger. Okay, so a lot of times they'll have a bump along that tendon. You'll see it, you'll feel it, and they'll be very tender in that area. They usually get injections first and then surgery to release the tendon. Lateral epicondylitis, tennis elbow, overuse injury, commonly associated with people who play tennis, or repetitive use of their wrist where they're turning their wrist away from their palm. Okay. That's important to know because you have lateral epicondylitis and medial epicondylitis. Lateral is when they bend the wrist away from the palm, and they'll have pain in the lateral aspect of the elbow. Medial epicondylitis is golf elbow or baseball elbow. Again, an overuse injury, and it's pain. It's pain in the medial side of the elbow. And it's caused from damage to the tendons that bend the wrist away from, toward the palm. I'm sorry. Medial is the medial side of the elbow and toward the palm. Okay, so again, medial, you're turning your wrist in, and lateral is away from the palm, lateral side of the elbow. Gout, we've all heard of this. It's a form of arthritis. They get redness, swelling, and acute pain in a joint, usually the great toe. It can occur in any joint though, and it usually only affects one joint at a time. And then osteoarthritis, everyone should know what an osteoarthritis is. It's just degeneration of joint cartilage and the underlying bone. This can occur in any joint. Most commonly are the big joints, the shoulders, hips, knees, but they can have it in their wrists. A lot of older people have it in their CMC joint in their thumb. Causes a lot of pain. They'll have a bump. You can get the Heberden and the Bouchard's nodes in their fingers. They can have them in their toes, their feet, everywhere. And it's extremely common. So I've included a couple videos about lumbar and cervical spine interpretation. There are a lot of YouTube videos out there. Be careful with what you watch, especially when it comes to imaging interpretation. Some can be way more than you need because it's geared toward a specialist, like a neurosurgeon or orthopedic surgeon that's reading these MRIs and all these advanced imaging, or it could be for a radiologist. Obviously, you don't need to be able to read an image like a radiologist does. But being familiar with these x-rays and the abnormalities that you'll see on x-rays is important. You need to know the difference between normal and abnormal. Obviously, if you're working in, a women's health clinic, you're probably not going to use any of this information. But if you're working in a family clinic, urgent care, ER, rural health, family practice, even a pediatric clinic, something like that, this can help you. If you're working in the hospital as an acute care NP, you probably need to be able to identify a lot of these things because you're going to look at the image before the radiologist reads it. It's not always available for you to look at unless you're in a clinic that has access to the imaging systems. You may only have a radiology report. So you need to be familiar with these terms. If you ever get a radiology report and you don't know what they're saying, look it up. Don't just assume what they're saying. Okay, don't just assume that, well, they put this in the impression, so, and it doesn't say normal, so obviously there's something wrong. Also, don't assume that, well, they put all this in the impression, there's all these things wrong, they have to go see somebody right now. Some radiologists are just very long-winded and they're saying that everything is normal. So look it up. Don't be afraid to Google or look at YouTube videos. If you're one of our students that's about to graduate, this is all good to know for practice. If you're one of our first level students taking this, it's good to know while you're in clinicals, because we're going to be going over a lot of these things in your different clinical courses. I hope this helps you. And good luck in either practice or the rest of your clinicals.